All right, I'm going to say we're good to go. Welcome to this month's IHPS Health Policy Grand Rounds here for the Institute for Health Policy Studies at UCSF. I want to begin by acknowledging the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. I really appreciate everybody being here today for this Health Policy Grand Rounds. I know that this has been first, I know that we've all been really excited about having Rosalie Picula here, and I'll introduce her in a moment. And also that this is a really challenging and interesting time in the era of health policy. For those who are not aware of it, I think one of the data sets that Rosalie has used in a lot of her own research is the National Survey on Drug Use and Health. And the team that runs that survey was entirely riffed yesterday. So I think there's a lot of opportunities for us to continue to advocate and highlight the importance of various data sets that we use, public health infrastructure that benefits the nation as we are continuing our work to advance healthcare for all people. So now I'm going to introduce Rosalie. I have known Dr. Rosalie Picula for many years. Turned out we went on the job market at the same time in health economics. And we met each other later after learning that we were like basically getting the same job offers. And then she would get an offer and then turn it down. And then I would get it, or I'd get the offer and turn it down. And then she would get it. And we got to meet each other after the market and kind of debriefed, which was a lot of fun. I have admired her work for a really long time. She holds the Elizabeth Garrett Chair in Health Policy, Economics, and Law in the Health Policy and Management Department at the University of Southern California Sol Price School of Public Policy, where she is also currently serving as interim chair of the department. No good deed goes unpunished, Rosalie. She co-chairs the National Academy of Sciences, Engineering, and Medicine Forum on Mental Health and Substance Use Disorders, and is a research associate at the National Bureau of Economic Research. I could go on, but I think those in the audience mostly know her work. She has been, she was at RAND for quite a long time before moving to USC. She continues to collaborate with her prior collaborators at RAND, and is the co-PI on the RAND USC Schaefer Opioid Policy Tools and Information Center of Excellence, which is a P50 research center in its 7th year of support from the National Institute on Drug Abuse, and has collaborated with many, many people. And someday she and I might write a paper together if we're lucky. So I'm going to hand it off to you, Rosalie, to take it away on your presentation.
Thank you so much, Joanne. And it's really a pleasure to be here. I apologize because I have way too much to share, but I welcome questions along the way, and I will just skim over anything if people have questions of it. Yes, Joanne?
And I forgot a bit of instruction that I was supposed to give is
Okay.
Please, people, there is a question and answer box in your Zoom. Use that for questions. And I'm going to keep an eye on that, and I might jump in periodically with any questions, which Rosalie said she would welcome if
And give me a
to have
5-minute
questions
warning
throughout
too,
the
please.
presentation. So I'll be keeping an eye out on that.
Great. And a 5-minute warning would be great. So, all right. So the work that I'm going to be sharing today is a body of work that has a large number of contributors that I want to recognize here. You're going to see some additional names as we go through. And it's largely been work that's been funded by the National Institutes of Health, which I am very, very grateful for. And I want to be sure to disclose I don't have any financial conflicts of interest. So many of you at UCSF are well aware of the changing cannabis policy environment over the past 3 decades. And the transitions have been slow at first with medical cannabis policies and then legalization often in the same places. As of June 2024, we have 24 states plus Washington, D.C. that have legalized adult use, and another 38 states that have allowed for medical cannabis through what are referred to as comprehensive medical programs. And these are programs which allow both high THC as well as CBD products on the marketplace. Nebraska is the one that's the most recent one that's missing on this map. Despite this variation in state policies, however, the federal government, as of still today, keeps cannabis as a Schedule I drug federally, which has created a very interesting policy landscape in the United States. Additionally, that since the December 2018 Farm Bill, which legalized hemp products, which is basically any of the cannabis plants that have less than 0.3% THC at the dry plant level, legalized, can be sold even in states that have prohibited medical and or recreational adult use programs. That has dramatically changed the landscape and is actually making our evaluations of the public health impacts or the benefits of these policies much more complicated, because our idea of what is a treated state and what is a control state is not as simple as a lot of people have presumed, which has led to a bunch of studies that have, in my mind, not been as cautious as they should be in drawing conclusions. I'll talk a little bit more about that, but it's hard not to get started by recognizing that the cannabis market in the United States is large. This is information that's being given by Marijuana Business Daily, which is a research organization that's been around since at least 2010 that's been providing regular economic input on the cannabis market and the cannabis industry. It's said that as of 2024, retail sales were estimated to be about $38 billion. Certainly over 35 billion is what we're expected, and this is just from the retail sale, and then additional activity that's contributed to the economy well exceeds that. Maybe we don't trust the numbers provided by the marijuana business, and so I want to just let you know that we have a federal bank of Kansas City which is providing very similar estimates of the economic impact of the cannabis industry. So this is not just information that's being fed by the cannabis industry as this being an important industry. You've got the U.S. Federal Reserve looking at it. When you look at the U.S. cannabis industry, I just want to put this in perspective, because we often think of this as all the small and pop businesses in the cannabis industry. And so this is a relatively small business. And if you look at the cannabis business industry as a whole, as mentioned in the previous slide, it's about a $35 billion industry. How does that compare to other industries that sell potentially addictive goods? Coffee at Starbucks, about the same size in 2024. Philip Morris, about the same size in 2024. You've got two tech companies, we're talking about San Francisco, similar sizes, and then a pharmaceutical company, Eli Lilly. And the idea is just to say that this is, yes, as a whole, as an industry, it's not as big as some of these other industries, but the leading sales company in the United States for cannabis is Curaleaf, and it alone represents at least 10% of that marketplace. So this is an important business. My work hasn't been so much on the business as much as it has been on how do we regulate the business in a way that enables the benefits of a legalized marketplace. And there are lots of benefits in terms of reduced criminality, throwing people in jail for simple possession and use, and jobs, not to mention tax revenue. But that doesn't mean that the market should be completely unregulated. The problem is that when you think about regulating cannabis, there's at least two big issues to think about. The first is that the cannabis plant actually contains over 100 different cannabinoids that have unique profiles, and the number continues to grow as the marketplace is continuing to change and evolve. This makes it really difficult. When we talk about regulating tobacco initially, we were focused on nicotine, a single product. Even with alcohol, we've been basically focused on ethanol. You can't just focus on one cannabinoid in your regulation, because you may be missing some of the important ways in which cannabis can improve or hurt public health. Also, which makes it even more complicated, people have become very accustomed to extracting those cannabinoids and developing concentrates from them and infusing those concentrates into a whole bunch of different products that can be administered a variety of different ways, all of which with very different harm or benefit profiles, depending on the mix of cannabinoids and the other ingredients that are included. And so it's really important to think about regulations, not in terms of a cannabis plant, which is this hybrid of different things, but perhaps in terms of the active ingredients that we might be most concerned with in terms of benefits or harms. When we look at, well, when we try to look at thinking of ways of improving this, the key barrier to having a very thorough and comprehensive approach in regulating cannabinoids as opposed to the cannabis plants is just that we don't have a system for tracking these products overall across the country, across the states. While individual states might have seed to sale tracking systems, they contain very different information across states and don't necessarily contain the detailed information of the whole cannabis profile of the plant, not to mention the profile of the other ingredients contained in products that are infused with natural cannabinoids. And so we're at a disadvantage to know what's being sold in these marketplaces and in what mixes to be able to know how to carefully regulate them. And that has created significant barriers. I also like to remind people that when we talk about regulating a legal good, and in this case, a good that's an agricultural good, there's a whole bunch of stages of regulations that we need to be thinking about if we're trying to think holistically about this product and the benefits and the potential risks that it can bring to a community. Cultivation, manufacturing, marketing, and sales. We know about processing, general cultivation requirements for other ag products. We know about manufacturing of other oils into infused foods, but their uniqueness of cannabis has something that we haven't spent a whole lot of time studying because the market is relatively new. We don't know what best manufacturing processes are. We let the industry tell us what those are. There is an international consortium that's trying to develop these, but they haven't been broadly accepted in the US. And so our sense of regulation has really been muted because we tend to focus on just a couple parts of this whole supply chain, cultivation, some extent consumption and use, and possibly if people care about marketing and sales. So fundamentally, we haven't given adequate attention in the policies that have been adopted across US states, across all of these spectrums. And while there are comparisons that are made, states adopt these policies to look like alcohol. I think we in the public health field tend to think of regulations similar to tobacco. We haven't applied many of the policy lessons learned from either alcohol or tobacco in terms of best practices for public health to the cannabis industry. Let me provide one really quick example here that just hit the news today. The Supreme Court said the FDA does have authority to regulate and reduce the flavors in nicotine vape pens. Fabulous decision for public health. Is likely to have a positive benefit in terms of reducing youth initiation of vaped nicotine products. We have nothing similar for cannabis. And in fact, efforts in California to try to adopt such regulations continue to get opposed by the industry and have not passed. We differ from other countries in this regard, and that's had important implications on some of the negative effects that have happened in terms of public health. This is a very simple representation of how our US market has varied a bit from other jurisdictions that have implemented legal cannabis. We're perhaps most similar to Canada than we are to other jurisdictions like Uruguay, which only allows sales in pharmacies and highly restricts the potency of the cannabis sold in pharmacies. Same with Malta, only allows social buyer clubs. There's no marketing or promoting of the product itself, only the environment, the social club in which it's sold. These are important differences in how other countries are approaching the cannabis product legalization and have important implications that we really need to understand better. And we attempted to do this to some extent in the NASEM report, make some comparison. I'll be drawing a few comparisons throughout the rest, but first I want to take a step back and say, look, a lot of us and on this call, I'm sure, have been studying alcohol and tobacco for decades and understand a bit more about the regulation of that product. What do we mean when we're saying cannabis policies aren't really taking a deep enough look at the ways in which states are approaching them? We asked this question now 6 years ago with a group of experts where we said, okay, we were talking to people who study alcohol, tobacco, and opioid policy, because opioid epidemic has been going on now for quite some time, and said, okay, what are the most important policy areas that we should be thinking about for regulating cannabis and monitoring across the states if we want to determine if states are taking a kind of free market approach or more of a public health oriented approach? We had to start by defining what we meant by these regulatory areas. So we said any law, regulation, or practice used to influence either the consumption or of particular products or might support how the retail and the manufacturing structures operate in their delivery of these products to the market, as well as the enforcement that might be allocated to these marketplace, retailer compliance, minimum legal purchase age laws around these policies. So our group of experts, which includes the list that you can see here from the publication below, came up with the following 18 areas. And I do want to raise them. I think a lot of people are going to go, oh yeah, that advertising restrictions, that's a bit general. We did think about it more deeply, but we just started with what name the areas. So advertising restrictions, cannabis possession limits, this ties into decriminalization policies, clean indoor air and smoke-free laws related to the ability to smoke cannabis in different areas and expose youth and others to secondhand smoke, cultivation and manufacturing operations restrictions, things like use of pesticides or the size area of the grow, trying to initially to keep the market small and cottage industry by restricting the amount of area that in which people could grow, and then manufacturing, what were the manufacturing practices required, delivery restrictions, would it be allowed or not allowed, home cultivation restrictions, both under a medical cannabis policy as well as under our legal policy, impaired driving laws, what was going to be the presumed level for impairment if using cannabis and caught with a DUI. We have here medical cannabis restrictions and requirements because some of those restrictions aren't initial restrictions adopted by the state weren't really all that restrictive. And so while other states that adopted more medicalized programs following a medical pharmaceutical model were, and so we thought about that as being a potential important aspect of regulation. Packaging and labeling restrictions, requirements, penalties for adults who possess cannabis and use. This is simple. This is different for just the possession limits, because possession limits may apply to medical patients, whereas this would be any criminal charges. At what threshold would you face criminal charges? Physical retail availability restrictions, hours of operation, things like that. Product design restrictions. Can you infuse it with food? What sort of other ingredients can be added? Retail price restrictions. Do you allow for happy hours or bulk sale days or big promotions in your state? What are the retail operations? Do you require security? Do you allow, check for ID inside the store or outside the store? Are there locations where you are not allowed to set up a shop? 15th is state monopoly, which in 2019 we kind of hoped would actually happen. The state of Vermont was actually considering it. We kept it in part because Canada does have this model, allows this model. So we thought it would be important, although we don't currently have any state monopolies in the US. Taxes, track and trace requirements, basically indicating from the seed to the final product, what plant did it come from and where did it go? It's interesting. These were largely adopted initially as a way to prevent diversion into the illicit market. When in public health, we think of these sort of products as being a way of tracking whether contaminants or inappropriate additives are getting added into these products. That's not how they're necessarily thought about yet in the cannabis market. And then youth policies. To what extent are there policies in place to try to reduce youth access through minimum purchase age laws, through ID checks, through compliance checks and the like? So these were the 18 policy areas that our group of experts said are likely to be the most relevant for reducing excess use of cannabis by adults, any use by youth, and impaired driving under the influence of cannabis specifically. Now, each of these has a bunch of different details. I highlighted a few, but let's just take a deeper dive into one, product design restrictions, because I want you to realize that we didn't think about these as just simple 0-1 categories either. We thought about these in terms of looking across states, what would be the likely relevant aspects of these policies that mattered. And remind you, we were doing this in 2019, and we had two important concepts in mind. What type of variation do we expect to be important, like a cap on potency for different products? We thought that would be really important in the cannabis market. And then what variation do we actually see in state laws that would allow us to capture variation in this product dimension and be meaningful? Now, many of the areas that we thought about didn't have a whole lot of variation yet. And so our actual measurement of this in 2019 wasn't as widespread as it could even be today, now that we do have a couple of states that have imposed more potency caps on at least concentrates and vapes. And so keep in mind, this was done in earlier years before some of this took place. But we looked at whether or not products were scored so that individual consuming them would know what a single dose was and had a meaningful comparison of the label to dosage to know how much they could consume safely. Can cannabis products look like regular food items, Pop-Tarts, Doritos, or cookies that might be confused, gummies confused with other products? Was there a cap on the total number of servings inside the products? Are there restrictions on what can be mixed with the products? A lot of state laws initially had this. That's starting to change. We now have beverages containing cannabis that wasn't initially allowed. And are there restrictions on the way in which the products are designed to be particularly appealing? This is the product itself, not the label and packaging. And so each of these dimensions, we looked across the states that had legalized and had medicalized, and we looked to see the extent to which we can rank the states in terms of how strict they were in adopting strict policies versus relatively less strict or more lenient. Any state that had not made cannabis commercially available was given a score in this product regulation about the highest score of 1. That's the most restrictive. But any state that had medicalized or adult use laws then would start at 0 and would get additional points based off the extent to which they had some of these dimensions that we were already seeing across states. So high potency, concentrated cannabis extracts, we were expecting this to pass much sooner than it did. It finally did pass in 2 states, so we gave it a big weight of 0.2. Caps on potency for flower, not likely to happen, but we still thought it was possible. Flavored cannabis vaping products getting banned, we viewed that as being more restrictive, so we gave that a 1. And you can see, so we went down and looked at the areas where we expected based on what state laws were doing and what we anticipated from a public health perspective, how much of an impact they would have. So we did this for each of the 18 areas. On this page, I say 17 because monopolies didn't occur, so we don't list it as part of our policy scale. We also give it a weight of 0. It's in the background, but we don't talk about it because it hasn't happened. And if you look at the implementation, this is just what are the laws on the books that the state implemented for each of these regulatory areas. If you look at the average score back in 1999, which was the first time we did this, this is when we had about 8 states that had legalized cannabis by then. And what you can see is that the score is already off of 1 because there are aspects of these regulations that would apply to a decriminalized state, such as cannabis possession limits, where you can see just a little bit lower. The bigger one that's lower are things like clean indoor air laws, which has a very low value. That's because it just didn't exist in any of the state laws. And so it wasn't an area of regulation that had been picked up. So the restrictiveness was actually quite low. Same with impaired driving. A few states had it, but most states, even if they had medical or decrim policies, didn't have rules specific to cannabis for DUI. So as you look at this policy over time, so I was just mentioning a few, as you look at this policy over time, go to 2009, fast forward, many more states have legalized. We have no legal cannabis states. So overall, there's not much change in the average implementation rating of our cannabis policy score, although we are starting to see a little bit of movement in a few of the areas. Home cultivation here is starting to become a little less restrictive with the medical cannabis laws because several of the states allow for home cultivation and the requirements weren't too strenuous. And then impaired driving laws started to become a little bit stricter. By 2019, when we have about 7 states that have legalized, we start to see more movement in the implementation of this cannabis policy scale across all the different dimensions and in particular overall. So overall, we're starting to see it fall by about a quarter. Remember, the maximum is 1 is the most restrictive, 0 is the minimum. And what's interesting is that you see, things like product design restrictions, something that we thought would be pretty important. We start to see declines in term, even though more states are legalizing, they aren't adopting some of these restrictions that we expected them to, which is why this product design restriction is falling. Other aspects are actually, here we have medical cannabis restrictions also became looser over time, track and trace requirements. More were adopting, but again, the degree to which we expected certain elements to be adopted, they weren't adopted, so it became relatively less restrictive. But we had areas of the policies that became more restrictive. Clean indoor air laws. States started addressing this and being more specific about how it applied to cannabis. Impaired driving laws were the same. So this is just the laws on the books as they existed. The second thing we asked our expert panel was, okay, assuming that these laws were passed with the highest fidelity, all aspects of our DUI or all aspects of our clean indoor air, all aspects of our product restrictions were implemented as strictly as they could be, how effective would they be in your mind at reducing general excess use in the general population, youth use, any youth use, because no state legalized with the intention of encouraging youth consumption, and then which of these policies would be most effective at reducing impaired driving. And what you can see, monopolies were very highly rated by the group because based off the evidence from alcohol and tobacco and what we were already observing in Canada. But there's some variation in the relative performance of some of these product restrictions based off the targeted population. But things like physical retail availability, which was highly ranked, whether you're looking at general excess consumption for adults or youth consumption, got a pretty high efficacy rating, meaning if it was implemented as we suggested in terms of the most restrictive way in a legal environment, would it be effective at reducing these things? Some things were yes, and some things like track and trace were not viewed as being terribly important. So from this information, we have this efficacy rating, which is not time dependent. It's based off of their belief in 2020. We did a modified Delphi process to extract these weights, and then we did it multiple times to get convergence on the weights. So those median values were based off of a lengthy process I didn't go into, I apologize. But basically, based off of those weights, we then multiplied that expected effectiveness against our implementation rating and sum them up across all of the different dimensions, leaving monopoly out, which is why 17 is left there, to get our overall cannabis policy score, which we then normalized so that we could get this scale, the CPS scale, in a range from 1, meaning the least restrictive, to 100, the most restrictive. So if you look in 2019, the median cannabis policy scale score across all states was about 76.5. So it looked like most states weren't terribly restrictive. That's not surprising. We only had about 7 states that had legalized recreational cannabis at in 2019. The lowest might be of interest to some of you. I thought it was going to be California. It was actually Nevada, and the most restrictive was Indiana. And this again is taking each of these policy implementation ratings and multiplying it by the fixed policy efficacy score. And so you see things like, where's my, I was looking for delivery restrictions is highly rated. I was looking for taxes expected to have a very high effect. Lots of jurisdictions were taxing, although they were not taxing based off potency. So they weren't viewed as being terribly restrictive. Medical states don't tax. And we multiply it by the efficacy ratios to get the overall effect in our policy scale. So this is a picture of what our cannabis policy scale looks like as it changed over time across all states. The dashed line on the top is the weighting of our implementation scores based off of efficacy targeting excess use by adults. The solid gray line is efficacy ratings based off of targeting youth and use of cannabis, and the darker line is impaired driving. And what you can see is, prior to the Ogden memo and then the subsequent Ogden memo, there's not a whole lot of regulation that was happening across the states because there wasn't a good understanding of how the federal government would respond to that regulation. With the passage of the Ogden memo, there was in 2009 and then a refinement in 2011 and 2013. There was some back and forth. You start to see states becoming more engaged in how they were going to regulate not just medical cannabis, but adult use as well. This gives you a visual of what does this cannabis policy scale look like within states over time. And I just shrunk the period to 2009 and 2019 to give you a sense about it. The first thing I want to point out here is about a third of the states basically have very little movement in their cannabis policy scale. And these are mostly the states that had not yet medicalized even as of 2019. So in 2009 and 2019, there's very little movement. So you have about a third of states that are just basically doing nothing. What's important about the scale, let me just remind you quickly, we are trying to consider penalties associated with possession, so decriminalization policies, in addition to medicalization policies and adult use policies. And the importance of considering all three is that some of the states that medicalize go on to adult use. At the same time, other states that were really slow in regulating started picking up medicalization, and they did so in a more restrictive way. Our prior system of considering these as dichotomous indicators of just a change ignores some of that focus on how they were regulating, which the scale is supposed to be picking up. And what you can see is that even these early adopting states for adult use or medical, California and Colorado's down here at the very bottom. In 2009, they had relatively low cannabis policy scores compared to many, many states, even in 2009, before they legalized adult use. In other words, their regulation of medical cannabis was much, much looser than that of many other states. You see Washington actually up here, looking much more like most other states that had medicalized in 2009. Another interesting point is that a few of the states actually became more restrictive between 2008 and 2009. Of course, Montana kind of stands out here, but Georgia did the same. They actually became more restrictive over time. And what that allows us to do is capture some of that differential exposure now moving to opposite directions and when it's changing when we look at harms. This is just one more look at how the cannabis policy scale compares to those dichotomous indicators that people usually study when evaluating the impacts of policies. And what it shows is that in 2005, some states have started to adopt medical policies, but there's not a whole lot of difference in our cannabis policy scales between states that had prohibition, states that allowed decriminalization, or states that had medicalized. The variance in these CPS scores are completely overlapping depending on the state. If you look at 2012, right before states started legalizing you see a lot more variation in how states are choosing to medicalize cannabis in terms of the regulations. And now in 2012, medical cannabis states are starting to look pretty different than states that are prohibited or only decriminalized. In 2019, when we have legalization of adult use, you start to see that the CPS score shows that these adult use states look fundamentally different than medical state or decrim states. And more importantly, what you see in my mind is that these medicalized states are pretty homogeneous. They're starting to adopt policies that are pretty consistent and pretty regular, different from what was happening earlier in the period of evolution. What does this mean? Why is this useful? Does this add any real new information? That's the important question that we wanted to ask ourselves. So we started using this cannabis policy scale immediately to see, does it tell us anything new about adult use of cannabis, or more importantly, probably youth use of cannabis? Because most of the studies are early on that were evaluating the impact of these regulations were very concerned about what was going to be the impact on youth in particular. And as you can see here, if you look over the time period from 2002 through I think this is 2022, on the NISDA data, Joanne, I hadn't heard that they just killed that audience. That's so sad, or that office. What you can see is that over the time period, we see use rates among all adult populations generally rising, but 12 to 17-year-olds has been fairly fairly flat during this period when there's been lots of change in cannabis policies. And the question is, does it mean that these policies really aren't having any impact on youth? So to look at this, we went to the National Survey of Drug Use and Health. We have been using the aggregated, I'm showing you findings here from the aggregated state level data. We are also in the RDC looking at the restricted data, but I can't talk about those results just yet. I can say they're generally consistent, which is why we produced this paper showing the aggregated effects. And what you can see here is that our cannabis policy scale does in fact have a negative and statistically significant effect on adult use. In other words, more restrictive states, an increase of 10 points, because our scale goes from 0 to 100, a 10-point increase, which is a 10% change in our cannabis policy scale, becoming more restrictive, is associated with about a 1% decline in adult use of cannabis. This is entirely consistent with what the general literature had been showing about medicalization and legalization. So that's not terribly surprising, but just reassuring for us. When we used our youth-specific scale, what we found, contrary to what has been found in the literature, and I should say these, as you can see in each of these columns, the specifications differ in some of the underlying assumptions, but the result is generally pretty consistent. Same different alternative assumptions, but in the case of youth, what we find is generally a negative and in important cases, statistically significant association between our cannabis policy scale, meaning states that are more restrictive in their approach to cannabis in terms of regulations are associated with lower prevalence of youth use. This was novel. This hadn't been shown. In fact, the prior research at all suggests that there was no effect of legalization at all on youth use. This is saying, yes, legalization, which makes it less restrictive, is actually associated with about a 0.2% increase in youth cannabis use in the past year. Okay, that's interesting. What about alcohol? A big question in the public health field is, what has cannabis liberalization done to alcohol misuse? Because if it actually reduces alcohol misuse, that could be actually a public health win, even if we are seeing a rise in use among adults and youth. And what I'm going to show you here, this map is published, but other findings are not published yet. But I'll show you them. Scale and the alcohol policy scale, which was constructed by some of the team, Tim Namey and Jason Blanchette and Marlene O'Leary earlier, to describe the overall alcohol policy environment, has been shown to be quite a very valid measure for describing the alcohol environment beyond just taxation. And what we found is that there isn't a consistently positive or negative correlation between our alcohol policy scale, which we goes from 0, least restrictive, to 1, most restrictive, just like our cannabis policy scale. In fact, we designed our cannabis policy scale to be comparable to the alcohol policy scale so we could look at them together. Some states have a negative association where alcohol is basically not changing, cannabis is becoming liberalized. Those are the blue states. And then other states, you have a positive correlation. In the case of Washington, interestingly, both are becoming less restrictive. In other states, you have both becoming less restrictive here for Washington, more restrictive in some of these other states. So the fact that the alcohol environment may or may not be correlated with the state in the state that you're looking at suggests that controlling for the alcohol policy environment could be important in teasing out the relationship of the effect of cannabis liberalization on alcohol-related harms. So when you include both these measures of alcohol-related harms as well, or alcohol policy scale, as well as the cannabis policy scale, I apologize, this is not very clear. This is again using the NISDA aggregated data. This is alcohol use among 12 to 17-year-olds over the period of 2002 to 2018. When we looked at alcohol prevalence for youth, we did see there was a small increase in the prevalence of use, which might suggest that they're possible substitutes. However, when we looked at youth binge drinking, which is what I'm showing you here, the binge drinking results overlap with null results. They aren't, it's not clear that there's an increase in youth binge drinking in states that have more restrictive cannabis policy with regard to when you account for alcohol policy. That's interesting and important. Okay, there may still be a substitution effect for youth. What about for adults? Because adults matter even more. Let me go back here to the adults, because adults are more the market. When we think about the overall market, youth are important. We care about youth as a vulnerable population, but when we think about sales in the overall market, it's adults' consumption that's going to be concerned. If we look at adult use, just simple prevalence, 30-day prevalence, we get very inconsistent results. There's no consistent relationship across our specifications. When we look at binge drinking, which is what our measure of the cannabis policy scale is targeting, excessive cannabis use among the general population, here we see stricter states, states that are more tightly regulated in their approach to cannabis markets, are actually not associated with any increase in binge drinking. In other words, they're not substitutes for adults. That's a very different finding from what we're seeing right now in a whole host of studies looking at use as well as sales data and even the FARS data. Am I going the right way? So let me show you what happens when we look at the FARS data, which is the fatal crash data reported by all states with differential testing for both alcohol and cannabis. There's an imputation for alcohol testing has generally gotten better over time. Most states do it fairly consistently. Cannabis, not so much. So those of you who use the data know there's lots of quirks. We were very careful in looking about these. This is a paper that's currently under review. What I'm showing you here is findings from a model where we looked at only only cannabis involved crashes, another run that looked at only alcohol involved crashes, no cannabis included. And then we separated out crashes that involved alcohol and cannabis. So this is the crash is the unit of observation, not the driver. So we attributed any positive test to everybody involved in the crash. Those are some important details people might have about the how we approach this. We tried imputing for people who didn't, to states that didn't test and taking them out entirely. The results that our cannabis policy scale is only associated with crashes involving cannabis. And higher, more restrictive states are associated with lower cannabis involved crashes, whether you look at cannabis only or alcohol and cannabis together. We do not see that more restrictive states in cannabis are associated with alcohol crashes. We do not see a substitution effect. And importantly, we don't see that more restrictive alcohol policies are associated with more cannabis involved crashes. In fact, both tend to be protective. Again, this is a fundamentally different finding than what has been seen in some of the literature using simple dichotomous measures, suggesting that the type of cannabis regulation used is really important. Now, I'm going to have to speed through a few other things, but I should stop here and see if there's any questions on that before I raise some findings looking a little bit more broadly at certain subscales.
Great. So a question came in that was really more related to some of the thinking about the cannabis industry as a whole that you discussed earlier, which I thought was really intriguing. So Mitchell Colbert noted that the ASTM International published a study last year that showed in California that cannabis packaging waste, which includes vape waste, is a bigger waste stream than like paint, oil, and
Wow.
batteries. I know, like
Wow.
worse than oil and batteries. Yet there's not any infrastructure really to recycle it or deal with it. And so he asked if you had any thoughts about the pollution waste management component of this industry and whether there's any regulatory action in that area and whether there's kind of framing of it as a public health issue in and of itself, given what we know about pollution and public health.
It's a great question. And as of right now, we have very little incorporated in the cannabis policy scale because at the time when we were doing this, it just wasn't something states paid any attention to. There was discussion that it could be important, but we saw zero discussion in the state laws when we were doing our initial scan back in 2019. Now, that doesn't mean, and this is a very important reason why we're hoping to get some additional funding to go back and reconsider, okay, what other policies really are relevant to be considering from a public health perspective and go back and reconstruct it retrospectively as well as going forward, because some of the things we thought weren't going to happen are actually now happening and we should try to capture that and do a better job. It's a great point.
Great. Let's see, there's another question that's come in from Johannes Thruel. Said, thanks for sharing the findings on binge drinking. He's curious if there were any associations with the number of drinking drinks or number of drinking days among adults to get a sense of the overall exposure.
That's what we are planning to look at and co-use as well in the restricted NISDA data. And those are results I'm not allowed to talk about yet because they haven't been approved.
Hopefully somebody will be there to approve
I know.
someday.
They never come out.
Okay,
Fortunately, it's
well,
old data.
okay,
So
we could go on about that for a while, but that's
yeah.
off the topic.
Let's
So we're at about 10 minutes.
Yeah, I'll try to breeze through just a couple points. I know I can't go through all of it. I do want to raise a couple points though. So this cannabis policy scale is a bunch of different things weighted a certain way. And there's a genuine question of what aspects of the cannabis policy scales really matter the most in terms of impacting cannabis. We constructed it like alcohol. Maybe cannabis is not like alcohol, and we should kind of think about this. So we started looking at some of the subscales for our cannabis policy scale to see where are we seeing states move in their regulation. And this is use measures down at the bottom. It's relatively low and it has fallen a bit, become less restrictive over time because many states are no longer criminalizing cannabis use. That's not surprising, but the ones where we're seeing some bigger dips are actually in the product subscale and in the market subscales. And so we were curious to think, is this going to be important? We think it should be important, and we want to do future work in the subscale to look at how approaches restrictive, whether more restrictive or less restrictive environments are generally better at in changing use outcomes and which of these subscales are most important. We don't have that yet. We put in a grant. We're hoping we can get the funding to do it. But what I can tease you with is some of our preliminary findings and just want to raise a few points. Product regulation, which is part of the whole product subscale, is important because there is a lot of change in legal markets, whether you're talking about Canada or the US and the types of goods that we're using. This is a graph using the International Cannabis Policy Study run by Dave Hamlin. A few of us are also part of that committee, and they're tracking things in Canada as well as the US, and shows trends in the prevalence in a household population of use of different products, which is important for us to know what are the harms. Different products have different harm or benefit profiles, and we need to be aware of that. Basically, we're seeing a decline in dried flower, increase in edibles, now a stabilization in vape oils, with a slight rise in concentrates. This is what we get from household survey data. If you look at the marketing data from the marijuana industry, which I always like to do, they break it out a little different. They have things by THC versus CBD. But if you try to kind of pull how close does our survey data look like the marketing data, basically it turns out if you group all the flower and buds, whether it's THC or CBD, with the pre-rolls, which is the fastest growing product in the industry right now, you get about 48% of the people interviewed who are purchasing cannabis say they use flower material. It's actually lower than what we're seeing in survey data, possibly because you're getting more regular consumers. Edibles are around 26% when you combine CBD and THC, and vapes are around 24%. So vapes and edibles together are now representing more of the market when we think of sales than flower material are. And that's important because the potency of these products is substantially higher than that of flower, with the possible exception of pre-rolls, which can get some additional potency sprayed on them. So that's just about product regulation. It could be important. We aren't doing much across the states to limit this, with the exception of 2 states, which have recently adopted caps on concentrated vapes and tinctures, and that's I'm Connecticut. I want to say no. I'm going to get it wrong. 2 states. I'll come back and name them, and when I can make sure I get it right. But also important is the marketing and promotion, and this is something I know this audience probably knows very well. An email today from the Marijuana Business Daily, which is the main industry rag, I should say, market, what's happening in the market news, basically said beyond THC levels, what matters is branding, packaging, promotions, and these things are important for heavily influencing consumer choices. And we basically know that. We've got lots of research that shows that. But I want to point out that we have lots of research that promotes that, it shows that. But how important is that for harms? And so there's been a series of studies. I'm going to wrap up with this because I know I'm running out of time, but let me just get through this one study really quickly. There's been a series of studies that said, okay, we want to understand promotion, but it's hard to do because the market areas and different streams. So some of the studies now are trying to say, okay, let's take a look at the cannabis industry consumer holiday, April 20th, which is basically the day that everybody expresses their freedom of being able to use. This was true before legalization. It's especially true after legalization. What happens to, we don't have good survey data on use, so let's look at something that shows harm, cannabis-related ED visits, and see what happens to cannabis-related ED visits when 420 rolls around. Now, why should we be thinking 420 is any differential promotion? Well, if you follow the culture at all, you'll see that that's actually a time where it is heavily promoted. And recent study by Rosanna Smart and colleagues at Rand and UCLA was presenting an APON where she actually shows in California seed to sale data a huge pricey discount associated with sales sold specifically on 420, a bigger reduction in prices than even the week before the holiday hit. So there's some decline in price in the week before 420, but a huge bump in the price of cannabis sold on 420 in the state of California. Okay, so maybe we can use that to help us identify an immediate impact of excess promotion being price cuts as well as advertising. So we can't tease out which it is, but does that do anything to cannabis-related ED visits? So we looked at this in some nationally representative, well, it's not nationally representative, a data set that contains national claims from a single commercial insurer, Optum Labs. We looked at patients under the age of 64. We didn't want to look at elderly because Optum is largely commercial. Medicare Advantage runs a little differently. But we looked at this by the individuals under the age of 65 over the period 2016 to 2023. And what we did was the same thing that's actually been done in a few other states or a few other studies. We looked at ED visits on 420 and we compared the rate of ED visits on 420 to 1 week before, April 13th, and 1 week later, April 27th. And we said, okay, is there any increase in ED visits on 420, which can be narrowly and precisely focused on the marketing and discounts of cannabis on those days? And if we see a difference, we can say it's promotion effect because we know that there's a huge price difference and we know there's more promotion on that day or building up to that day. But, you know, you might not believe us with the right before or right after. So let's do a falsification check. And we do the exact same thing on March 20th, looking at a week before and a week after, and May 20th is a week before, a week after. And those are our counterfactuals. So we basically run this test to see if there's an increase in ED visits on 420 relative to the week before, week after. And does that differ from March 20th versus May 20th? And what we find is that, yes, there is a very negative and significant effect. And this is a paper that's about to come out in JAMA Network Open. We see a 17% increase overall in ED visits on 420 relative to the 1 week before and 1 week after, timed with increased promotion and lower prices of cannabis, showing a more direct tie that excess use of cannabis does have a potential harm. We see it concentrated in individuals between the ages of 25 and 35. We also see a larger effect in our data in the earlier 2016 to 2019 period than the later period, which we haven't quite nailed down why yet. We need to do some more investigation on that. But what's interesting is that we weren't the only ones to do this study. This was done in Canada a few years earlier. Canada, it was done in a single province, British Columbia. They did the exact same thing, but Canada has a much more limited and restrictive promotion role in general. It doesn't allow any sort of branding. It requires plain packaging. The promotions are much more restricted because they're able to in Canada more so than the US. And while they do find an increase in the ED visits among the same age group we do, their increase on 420 is less than half of what we see. So there is a promotion effect that impacts consumption and encourages excess use to the point that it generates an ED visit. This is the strongest evidence in my mind that this is a potentially important avenue that we need to focus on for future regulations. So I know I'm out of time. Let me just summarize.
Well,
Nice
I want to ask a question that I think is actually going to relate to your summary and lead into perhaps your summary. Laura Schmidt, who I think you know,
Yes.
noted that back in the mid 90s, when California was doing this, advocates claimed that we would save lives from alcohol-related traffic fatalities and having products that might be a better quality and so on. Anderson and Reese's traffic article got lots of play. Have state regulators seen your data and responded to that? And Laura ends her question with, were we sold a bill of goods?
I think we were sold a bill of goods because we did not put in the guardrails that would have been necessary to allow it. That doesn't mean that we can't do it, but we keep trying to do it now after the industry is there and their promotion and hold of congressional policymakers, particularly in California, have limited our ability to put up those guardrails after the fact. Many other jurisdictions have learned from our mistakes and are taking a more careful approach. I don't know, I can't say the results are like, we still see ED visits and harms in Canada, which has taken a much more careful approach and regulation. You're not going to stop them, but they are not seeing the magnitude of the effects that we are. All the products have to be reviewed by the Health Canada and registered, so they know what's going in them. If you're buying something in Ontario, the labels are read in the same sort of way as the products in BC, so you can go anywhere and know what you're getting. So there's other things that are in place to help protect some of the potential risks to consumers that states are just not doing because they don't have the federal partner to impose it and provide the resources.
Well, we're out of time. Thank you
Yes.
for all of this rich information from your research and your expertise in this area. I know you have some Zoom meetings scheduled with some of
Yes.
our colleagues, and I hope I get to, and I'm sure others hope they get to run into you soon at a conference
Yeah.
in
Thanks so
person.
much.
But thank you for taking the time to do this with us today.
Thank you. I hope I can share more insights on more information when we get to it soon.
Yes. And I hope your NISDA data makes it out the door.
Oh, yeah, that is really not good news.
Yeah, well, thank you everybody for joining us
Yes.
today. And the recording of this will be shared soon so you can tell people who missed it that there's an opportunity to see more. And everybody have a really good rest of your week.